Please welcome to the stage, Keese, CEO, Capital Advocates.
How's everybody doing? How is everybody doing? It's so great to be out here with everybody after years of doing this virtually. Isn't this better? So it was great hearing all of the human stories from our last couple of speakers. We're going to talk about policy. So bear with me a little bit. I'll try to make it fun, but this isn't really the real world. You know, this is like Disneyland East from Washington, D.C. But I want to tell a little bit of a story because we've spent a lot of time today talking about, this great thing we all love called direct primary care. But how did it get there? And why do we call it direct primary care? Where did that all come from? So if you go back to 2006, there were really a couple of practices around the country doing this. Garrison Bliss from Q-Liance, then I think it was Seattle Medical Associates in Seattle was doing this. There was a guy in Wheeling, West Virginia, Vic Wood, and I'm going to flash forward a little bit. And being in the Wild Wild West, look at these ne'er-do-wells. Do they look like the kind of rapscallions that would on the side of the road trying to hijack a train, or do they look like doctors? So back in 2006. Direct primary care was actually illegal. If you started a practice and you decided, hey, instead of charging fee for service, I'm going to charge a monthly fee, and I'm going to limit my patient panel size, and I'm going to really spend time with my patients. The first thing that happened in West Virginia or Seattle was that the insurance commissioner would knock on your door and say, hey, if you want to do that, you're going to have to capitalize like an insurance company. You're going to have $1 million in the bank. You're going to have to follow all the rules insurance companies follow. And so actually, these two gentlemen took it upon themselves to challenge that in the legislatures in the states. And Vic Wood was really the first one to do it. And he went to the legislature in West Virginia, and what West Virginia told him was, okay, we think you can do this, but we're going to make it so that you, Dr. Vic Wood, DO, are the only person in West Virginia that can do this, and everybody else that wants to do this can't. It's illegal. So his name was actually in the statute, and, so that really wasn't what we would call a good law, right? And we flash forward to 2007, just a year later, Garrison Bliss hired a lobbyist in the state of Washington, and they went down to Olympia together, and they actually did put the first law in the books that says direct primary care is a medical service. It can be an employee benefit, but it is a medical service. It is not regulated by the insurance commissioner. It is not the business of insurance. It's a medical service regulated by the State Board of Medicine like any other. And then there were some, loosely framed patient protections put in it. Like if you charge somebody up front a monthly fee and they decide to leave in the middle of the month, you have to give them like half their money back. Kind of nice, simple, fiscal patient protections that were in that. And so let's flash forward again back to 2009, a couple of years later. What was happening in Washington in 2009? Does anybody remember? Nobody? ACA, Obamacare. So, and Garrison's not, if anybody knows, he's not exactly a conservative, right? But he loves this sort of free market approach, and was one of them that really said, we've got to do something to protect this. And so Garrison came to me. I was then, running a healthcare lobbying practice in Washington, and said, hey, we got to stop this Affordable Care Act. It says that everybody's got to have insurance, and that all primary care is going to be, doled out through insurance. It'll stop this model in its tracks. I had never heard of the model, and now for 10 years I've been part of a direct primary care practice in Virginia. So I was excited about it. I had like, how can you actually do that? $50 a month for all the primary care you need, and the first question I get when I walk into a lot of congressional offices is, like, how can I get this? It isn't like, well, that's bad or that's good. It universally, people want it. So the idea, and this was late in the game in the Affordable Care Act, sort of fall of 2009, the bill was about to go to the House floor. And, so what could we do? We can't stop the train that's moving down the tracks. but could we put a provision into the Affordable Care Act that said direct primary care is in fact can in fact work with a qualified health plan to meet what was being created as the essential health benefit criteria, and have the primary care be delivered outside of insurance reimbursement by your doctor over here, and the specialty care be delivered by a qualified health plan over here. And that's exactly what we were able to do to put this provision in the Affordable Care Act. And we're going to talk a little bit about what's happened since then. So this map with all these nice dots on here, and there's over, if you look at Phil Eskew's DPC mapper, this is the latest count. And I think this is grossly undercounted. For instance, bigger DPC clinics like Iora, which is now part of One Medical Group. And by the way, I don't think it's lost on anybody in this room, the value of this service to people when a company like Iora, which is a primary care practice, is bought by a company like One Medical Group for $2.1 billion. That's billion with a B. And I'll remind you, Jeff Bezos only paid $250 million for the Washington Post. So people see this as a high value service, and that high value is going to come big into play in what we're going to talk about in a few minutes about stuff that's happening now. We have since 2009 convinced, so we got this in the Affordable Care Act with Maria Cantwell, who is a liberal Democrat from the state of Washington. We have a bill that we're working on right now with Earl Blumenauer, and Earl Blumenauer is also, besides being a big champion of direct primary care, he's head of the Cannabis Caucus and the Bicycle Caucus in the House of Representatives. We also have had co-sponsors on the other side, people like Rand Paul and Senator Bill Cassidy, who's a doctor, gastroenterologist from Baton Rouge, Louisiana. So everybody along the political continuum understands this is a good idea, and it's something that we've got to move forward with. We still have a lot of hurdles that we need to go, but what we did right from the get-go was to build a bipartisan consensus that people need primary care, they need more primary care, not less primary care, and that this direct primary care model was a way that we can try out to see if it really works. And I think the experiment has worked. So let's take a look at some of the growth since the Affordable Care Act. In 2009, you can see we had these laws in West Virginia and Washington. You flash forward, what happened after 2009 was this provision wound up in the Affordable Care Act. So employers really interested now in trying to reduce their overall cost of doing business. It was great hearing Dave Contorno talk about, hey, what did this room look like 4 years ago? What this room looked like in 2009 was really small. But, we've been able to grow, and you can see the DPC growth curve has gone. We now have passed state legislation that by and large harmonizes that provision in the Affordable Care Act and that original provision in Washington that says this DPC is regulated by the State Board of Medicine like any other part of primary care, and it's not insurance. And as I said, if you look at the complete map, you can drive across the whole country and really do almost a big circle around it. Now, these gray states that haven't passed laws yet, there's a couple of reasons. Some of them are really big bites of the apple that we're going to have to continue to attack, places like New York and California, where there are some regulatory hurdles we need to get through. But they've been very permissive, and there's ways to do direct primary care in all 50 states now. We're working on a law in Alaska this year. The clock ran out on that. I anticipate that'll probably pass again next year. So I think we'll continue to work on this, what I call enabling legislation that really does allow direct primary care to be counted as not being insurance. And you can see the growth of DPC practices across time. Really kind of, if you look at this graph, it really does kind of match where the legislation passed. So by getting involved on the political side, getting involved in the legislation, getting involved on the regulatory side, in each and every state, we've not only done this great thing, which is, to make sure that direct primary care is legal, but we've, put a big billboard up in the state that says open for business for direct primary care. And so employers and even a lot of health plans, we've worked with Medicaid plans, we've worked with state employees, and we're going to continue to do that sort of thing. So there's a ton of interest in helping this, what I would call advanced value-based model of primary care to move forward. And we are in fact considered under the federal law of MACRA as an advanced payment model. In other words, a model that advances a high value primary care set of services and allows in the fee-for-service case for this to be reimbursed in these new reimbursement models that were envisioned by the CMS Center for Innovation. We did this study with Milliman and the American Academy of Family Physicians a couple of years ago, and you know, you've seen all this data. I mean, up to 20% reduction in the cost of claims for employers. And you know, one of the other things we found is that virtually everybody in DPC, and you know, we understand why. You want to be able to call your doctor. Virtually everybody does telehealth, so a telehealth service is baked in. So I think you've probably heard the experiences from some of these physicians during COVID, where you know, a lot of them, some of them lost patients, and some of them had trouble doing business, but because direct primary care physicians are allowed to do things virtually because they don't have to get paid to do telehealth, it's a baked in part of the service, you know, a lot of practices didn't skip a beat, and a lot of practices actually grew. We also found in this survey, we're going to talk a little bit about this in a minute, that 57% of DPC practices were actually dispensing meds in office. And I think there's some great things that are happening there. We're going to talk about an exciting new program that the Direct Primary Care Coalition is working on in a minute. So again, I think a lot of these have been mentioned. There are still some pretty significant hurdles. And you know, I think Medicare is one of them. Nobody's ever going to put a gun to your head as a DPC doctor and say you have to work with Medicare patients, you know, in a fee-for-service way. But we've been working really closely with Medicare and the Center for Innovation to try to create some demonstration projects that would test this model out. The most recent one that looks anything like DPC is the direct contracting model. And while that isn't DPC, we agree, it definitely has moved the ball further. We're continuing to work really closely with CMS to try to get a model for Medicare. You know, there's so many Medicare patients. Wouldn't it be great if we could get Medicare to pay the DPC fee, either directly to the doctor or to the patient, and have the patient pay you? So those are some of the things that we're working on. We've talked a lot about the opt-out, the idea that most DPC practices, to do what they need to do, need to opt out. Well, this Center for Innovation law actually allows Medicare to waive those kinds of provisions. So if we could get something like that into a CMMI program, we would have to deal with, and we would want to deal with, the opt-out, so that regardless of whether you're opted in or opted out of Medicare, that you could see a patient as a licensed physician practicing in that state that would you know go in this direct primary care model, and so there wouldn't be that kind of thing. And of course there are the problems in the tax code, and you know, I think it's not lost on anybody. One of the biggest things prohibiting growth, particularly among employers, is this idea that somehow HSAs are not compatible with direct primary care. It is true. HRA plans, FSA plans, other parts of the tax code are, but here's a look at what the current state is, and we'll talk a little bit about what the way forward we think is going to be. The current eligibility rules actually state that if you have an HSA, it must be paired with a high deductible health plan, and that you can't have any other form of coverage that comes in between that. So because DPC is not a high deductible health plan, and to the IRS it sort of smells like insurance, what happens in the law is that because the IRS interprets this as a second health plan or some other form of insurance, it is incompatible with the FSA, and so with the HSA. So the remedy for that is that the individual that would have the DPC contract is now not eligible to fund that HSA. It isn't that they can't have the HSA, it's that they can't fund it. By the way, I'm sure wildly not complied with, you know, and any doctor that's sort of like, you know, answering questions, particularly a smaller doc, about whether or not you can or can't use your HSA, you ought to think about whether you have a tax law degree before you sort of answer some of those deep questions. But you know, the reality is, you know, there's not an HSA police out here checking that. But it's something we've got to change. In the Trump administration, they attempted to do some regulatory changes like this. They really didn't go. And some of them are sort of left out there hanging. And the Biden administration is probably not going to continue to try to promulgate rules that the Trump administration put forth. But both administrations are supportive of the concept of DC. The reality is, even those regulatory efforts were not going to stop us from having to change the law. And essentially what we want to do is we want to make an exception to these dated, antiquated IRS rules that says that a direct primary care agreement is not a health plan. It is a qualified health expense in the list of things that are in the tax code that are qualified medical expenses. So your toothbrush and your eyeglasses and your toothpaste and your aspirin, they're all qualified medical expense. But paying your doctor a monthly fee for primary care, not a qualified medical expense. So it takes care of those two things. And then it really says, if you have an HSA, you're allowed to pay the fee with the HSA. Or if you are an employer with HSA high deductible health plans, you are allowed to offer a direct primary care offering in addition to the PPO plan or the high deductible HSA. Right? So it would be fully compatible with these legislative clarifications. And we're working on sort of a new paradigm on this where there's other services that have this same problem. If you work in an employee wellness program and you have care coordination services, they can run into this problem. Telehealth runs into this problem. We're working, really closely with a number of stakeholders to try to make some of the waivers that were made in the CARES Act at the end of this year. We need to make them permanently legislatively, and one of those actually does offer a solution. So in this temporary set of rules that have been put in place for the pandemic, there is a provision. If you do what you're doing now as a DPC doctor, using telehealth, it's fine to use your HSA with that. That will expire at the end of the year. So not only do we need to continue to have that telehealth piece, continue beyond the end of the year, what the paradigm we're working in right now is to try to expand it so that all of these high value care services like telehealth, like employee wellness services, mental health benefits, direct primary care, other forms of advanced primary care that might still have some fee-for-service elements, that all of those would be accepted from these antiquated parts of tax law and the ERISA law, which is the law that guides how employers can offer health benefits, and that employers would be able to offer these seamlessly without fear of the tax man coming after them. So this talks a little bit about that Medicare contract. We can talk a little bit more about this, but even though it's not quite DPC, there were two victories that we won in this effort ongoing, and there are several DPC practices that are participating in this program right now. We'd like to get them further to the model where it looks a little bit more like DPC, but as you're probably aware, the original ACO models required you to do all kinds of reporting of data from your patients, 33 different quality measures. Those measures were actually reduced in this program to 5, and a lot of those are patient satisfaction measures that you actually want to go out there and capture for your businesses. And it required CMS to share data with practices about downstream claims. So the entire measurement for these programs is not necessarily how are you doing on your quality measures. The measurement is, are you keeping people out of the hospital? So they're not really asking you to measure a lot of those measures in your primary care practice. They're measuring them, and the data will say, if you're in a DPC practice and you've reduced hospitalizations by 57%, which is one of the figures that we've seen out there, you've heard before today, then that's proof of concept. And that would enable this program to continue as a more permanent program. So you can't have a conversation about what's going on in Washington without talking about prescription drugs. I think you've probably all been watching the news. The Democrats don't seem to even have 50 votes in the Senate, let alone the 60 that they need to pass this legislation to move forward. And so we've been talking to people on the Hill for a long time about the idea that, in direct primary care, we already do dispensing. As we saw in the Milliman study, 57% of DPC practices dispense medications right now. This is a chart that shows some of Clint Flanagan's posted prices on NextEra Healthcare. And this is comparing the NextEra Healthcare dispensed cash pay price to the price that you would walk into with a GoodRx card, a pharmacy discount card, and buy at the pharmacy as an individual. So you can see reductions in price of 16, 32, 14, up to $114 on a 30-day fill of these medications. So if you really want to talk about saving patients money, reducing their out-of-pocket costs, most of these, as you can see, are lower than the $10 copay that most of us that have a PBM have to pay. So why wouldn't you go in and pay cash for these services? And I know there's a lot of physicians out there that don't want to do the dispensary. It's a lot more work. You have to do all this kind of tracking of the meds and understanding this. That 57%, each and every one of those DPC practices does it a little different. So we're actually starting a program, and we've been working really closely with the generic drug industry because most of these are going to be generics. These are routine meds. There'll be some specialty meds included in this, but the kinds of specialty meds that you might see in a primary care setting, and these would be medications that you're probably currently spending a lot of time couponing or looking at patient assistance programs that are out there for people. So we're working on a solution that we'll have for every state. And also, you're probably aware, in I think something like 46 states, you are allowed to prescribe. There are additional states, and Texas is the most restrictive of these, where you're really not allowed to prescribe as a doctor. We actually have a solution for this too. So we've come up with what I think is sort of a seamless way for DPC docs to start telling Congress and telling your patients that they can actually reduce your prescription prices. And it's called DPCRX. So as a part of the Direct Primary Care Coalition's offering, we're going to now offer our members an ability working through AS Medications, which is our distributor partner, and a company called Lineal Health that we've put together with some pros that are some reformed PBM managers. In fact, Brett Drexelius, who's back at that Lineal booth you can talk to, was the chief growth officer of OptumRx. And Brett is now working with us and with Lineal Health to try to bring a streamlined medication program so that DPC physicians can dispense these meds in their practices and basically have it be seamless. One of the great reasons to do this isn't necessarily just convenience. It's medication adherence. This is good for your patients. When your patients leave the office, it's a 100% fill. They're taking the script home with them. In the states where we have some prohibitions, rather than the physician dispensing, the next day the med can be shipped directly to the patient, or the patient can get a card where they've paid that discount and they can go in for the $5 or whatever the cash pay price is, pick that up at any pharmacy. So there's lots of options in this. But the whole idea here is we're going to have DPC be part of the solution to reducing prescription drug costs in America without having to, frankly, monkey with almost any of the laws, some state laws we'd like to change, that are prohibitive of this practice being done. I think it's single digits percentage for fee-for-service practices that do this kind of dispensing, but in DPC it's 57. Maybe we can grow it to 80. Maybe we can grow it to 90. Maybe we can just have this be kind of part of the norm for DPC. So we're really excited about this program. We hope you'll take a look at the Lineal booth back there and really, these partners I think are committed, like Hint Health is, to having DPC be a part of their DNA and making sure that this practice model, goes beyond just primary care into medications, into other areas, really trying to expand the ecosystem so that patients like me have full access to a suite of services that your primary care doctor becomes your guide through the entire system. We know that's what people are doing now. Let's just try to make it easier for docs to be able to do it, take a lot of the hassles out of the way, and make a seamless program that isn't going to require them to basically set up a pharmacy in their office. So again, excited about this program. We're very bullish about continuing our bipartisan work in direct primary care in Washington and in the states. I don't know whether we have any time left, but I'd be more than happy to take a couple of questions if I'm not going to keep folks between you and your lunch.
So a couple of the problems that I've seen with Medicare is, number one, patients are penalized if they don't sign up for Part B and Part D right away. And wouldn't it save the government money if we did away with those penalties? Because if patients don't need those things, then they can go 5, 10, 15, 20 years without any Medicare benefits. Why not let them do that? And number two, a lot of us don't want to interact directly with Medicare. So what if you put it on the patient, and if the patient proves that they're part of a DPC practice, just by showing their last year's invoice, then they get 50% off their monthly premium for Part B, which runs around $150. So 50% of that would be the average cost of a monthly DPC practice.
Yeah, so great points. Number one, as I said before, nobody is ever going to point a gun to your head and say you got to take Medicare. It's just not out there. It's not part of the law. I think it's a mistake to counsel any patient not to sign up for Medicare because it is an amazing benefit. You may disagree with it at its core, but today there's really nothing stopping you, as long as you're opted out, from seeing a Medicare patient and having that Medicare patient pay you cash for your services. What we're trying to do is exactly kind of get rid of the regulatory hurdles that are there to allow Medicare to pay you that fee and have it not be in fee for service. But again, if we ever get there, the first place we'll get there would be in a pilot program that would be a demonstration. So you'd have to sort of probably voluntarily go into that. It's not going to be mandatory assignment. And in terms of, like reducing fees or penalties for opting out of Medicare as a patient, I'm not even actually familiar with a lot of those, but we're not going to re-prosecute Medicare here. I mean, it's the third rail of politics. Any member of Congress that goes up against Medicare will have instantly thousands of commercials saying, he wants Medicare taken away from us, and we'll probably lose their elections. So we want to fight the fights we think we can win. I think the tax code is one of them that we can win. Changing Medicare dramatically to fit our needs, we are not quite there yet. But let's keep working. I think we can get there.
Hello. So last year's summit, I think you discussed with the tax code that currently is written last summer, there was a cap in the HSA. I think it was
You're going to have to continue to speak up a little louder.
Sorry.
Even with the mic, I can't hear you.
Is this louder? Is this good?
Yeah.
Last year's summit, I think you mentioned that there was a cap written into the bill for using the HSA, like $150. And has that cap been eliminated currently as written? Or is
Well,
it still?
it's functionally been eliminated because I'll be honest with you, the legislation isn't going anywhere. As I said, we're looking at a lot of different approaches, and the approach that we're looking at right now, which is likely to be introduced at the start of the next Congress, would probably be fairly different than that. But I want to clarify the caps because they caused a lot of, as I think you're pointing out, division within this community. The caps never were caps on what you could charge. The caps simply said to qualify for this exception, you had to be an affordable DPC practice that was offering a benefit to a patient that cost less than $150 a month. So how many practices here charge more than $150 a month? I'm not seeing hands. That's what we found when we talked to them about the cap, and we said, that cap actually brought the price of the bill down from something like $10 billion over 10 years to $1.8 billion over 10 years, the way the Congressional Budget Office scored it. So the Congress, the Joint Committee on Tax put that in there as a way to keep the score down. And what we thought was, we actually had one practice that was above that, and they actually did leave the Direct Primary Care Coalition, and I don't blame them, because we weren't going to be able to protect them above that level. But that was such a fair trade to be able to say, we want the 2/3 of Americans that have a high deductible health plan that get coverage from their work to be able to have direct primary care. It seemed like a good trade. But let's be clear, that legislation is probably not going anywhere. Neither are some of the alternatives. We had a bill that we introduced before that didn't have the caps. That's not going anywhere either. But in this idea about harmonizing with telehealth and other value-based services at the end of the year so that we don't drop these great services just because the pandemic emergency might be ending, and it might not, is probably a better way to do it. And then we'll either have to have members of Congress offset these large numbers of tax revenue that the Treasury is not going to see, or say, just like they have for the last 2 years, we don't care how much it costs, Americans need this care. Either way, we're happy to get there. But I don't think the caps are a big problem for us right now. And what I would like to see is this community be unified around any solution that breaks this HSA barrier. Because if you're an employer growing a DPC benefit, having a DPC benefit, this is absolutely prohibitive to most employers. We're working really closely with groups like the Purchasers Business Group on Health, the Chamber, the National Association of Manufacturers. Candidly, even the Insurance Association, AHIP, supports this legislation. So we don't really have a lot of enemies on it. What we'd like to do is move it forward in a way that is practical. And if putting some constraints around it that will reduce the cost of the legislation to the Treasury is something we have to do, we'll take a look at it. But we're never going to want to have a bill that tells you how much you can charge. This one didn't. Well, without any other questions, thank you for your time. Thank you, Hint, for having us here. We're really excited and bullish about the future for DPC policy and continued DPC growth. Thank you.